Hello, friends. Today I'm going to take you through one interesting paper on endometriosis pathophysiology and management. This paper has been published in Lancet by D. Ziegler et al. Way back in 2010. Though it's an old paper, we will just visit a few basic mechanisms in pathophysiology of endometriosis and how it is affecting its management. We all understand from the Sampson's theory that there is a retrograde menstruation which could be responsible for endometriosis, or there is a coelomic metaplasia theory. But all the peritoneal fluid there in the patients of endometriosis has a lot of inflammatory markers, and as we understand, the fertilization process takes place in the ampulla of the tube, which is exposed to the peritoneal fluid, and hence these inflammatory markers will affect the process of fertilization itself. And these inflammatory markers will also cause immobilization of the sperm, like the interleukin 1 and 6, which is increased in patients of endometriosis, will directly make the sperm immobile. And also the tumor necrosis factor there, which is also increased, causes the direct sperm DNA damage. So gametal interaction and gamete itself gets affected in patients of endometriosis. Macrophage migration inhibitory factor is secreted, which also again affects the sperm motility. About ovarian endometrioma, we all understand it is SOL of there. By pressure itself, the follicles don't grow. A huge amount of inflammation also retards follicular growth, or exhausts follicle rather, and hemosiderin deposits and the chemical toxicity which is there also causes loss of follicles. All the ovarian reserve parameters like your AFC and AMH decreased, and the FSH goes up, and everything is affected in patients of endometrioma. Most important difference in a young lady with low ovarian reserve and that of endometriosis is, in a young lady with a low ovarian reserve, it is only a quantitative fall, but the quality of the egg still remains good. But that is not true with endometriosis. Endometriosis will not only affect the quantity but the quality of the egg, and hence the embryo will both suffer. Though the studies published on the embryo quality are published on both sides of the story, but it's a general belief that the oocyte quality and the embryo quality is affected even if the patient is young. There is also activation of COX2 and PGE2 locally, and that is manufactured by interleukin 1 from local macrophages. Interestingly, there is an increase in the steroidogenic factor 1, and that causes a lot of activity of cyclic AMP19 or here the CYP19 enzyme aromatase, and hence the local testosterone gets converted to estradiol. So there is a de novo estradiol production in these endometriotic deposits. Normally, this steroidogenic factor 1 is kept inhibited to keep the endometrium inflammation quite low in a normal lady without endometriosis. Secondly, not only there is an upregulation of aromatase, the conversion of estradiol thus produced to estrone, a weaker estradiol, is this inactivation is also less, and hence there is an estradiol preponderance in eutopic endometrium. Moreover, the endometrial cells in endometriosis patients proliferate faster than in normal women. So this really goes beyond retrograde menstruation, where not only the endometrial cells come there after retrograde menstruation, they also proliferate faster just because there's endometriosis, and that could be leading to the endometriotic deposits as such. Also, there is adrenergic and cholinergic nerve fibers are more in endometrium, and they could be contributing to dysmenorrhea. And there's a difference in the progesterone receptor isoform, and that changes, and that induces a progesterone resistance. So we find that not everybody will be responsive to progesterone, especially adenomyosis. There is progesterone resistance, and not the given progesterone will make a huge difference to that. And again, that is a takeaway point in patients of endometriosis. When you're taking for frozen embryo cycles, definitely you need to give a higher amount of progesterone to all these women. Now, the difference between the menopausal endometrium, which is pre-atrophic, and that can be revived back by giving adequate amount of estrogen and progesterone, and over a period of time that endometrium will pretty become normal, and we see so many women conceiving with egg donation cycles. But endometriosis endometrium is affected by an abnormal in situ estradiol production and decrease in the inactivation to estrone. So it is very much proliferative, and there is an overt resistance to progesterone, and both the things coming together makes the endometrial receptivity very, very difficult. All the studies, obviously this paper quotes the studies which are published earlier than 2010. They said that long-term GnRH agonists, then it was in vogue, like giving long-term GnRH agonists followed by IVF. And they said all that thing will definitely improve the endometrium itself. And this long-term GnRH agonist will positively affect the endometrium, and there is a reduction in nerve bundles also seen, which is seen in the histopathology. In those days, what would be the criteria in favor of endometrioma surgery? I think this holds true even today. Both is a unilateral disease. If you notice a rapid growth in endometrioma, there is a good ovarian reserve and there is no history of previous surgery, and this will be worth operating them, and obviously the chance of spontaneous pregnancy will go up. But on the other side, if you have a past surgery already done, there is a bilateral disease, there is a decreased ovarian reserve, obviously this does not favor into a repeat surgery. And again, we are on the other side would be, suppose you don't remove an endometrioma and you go for OPU, and inadvertent puncture of those endometrioma increases the risk of pelvic infection, and in a few cases even pelvic abscesses have been noted. So it's very individualized decision making depending upon a very holistic approach of knowing the age, the interests of a lady, the ovarian reserve, how big is the endometrioma, how proximal is the endometrioma to your probe, are the ovaries accessible, all those things will take a call whether you're going to prepone your surgery or you're going to go for ART first. Before ART, now that has some exceptions, like there is an associated hydrosalpinx because of chronic inflammation, what could be there. If there is severe pain and patient is very much symptomatic. Another thing is the ovary is not accessible. You may have to, ovaries all the way on the fundus, so probably you have to do surgery just to mobilize the ovary down. A large endometrioma where your follicles are not going to be accessible. And sometimes there could be a doubt about the exact nature of the ovarian cyst because there are a lot of solid areas and neoangiogenesis which you are seeing. But when you do surgeries, we have the literature then has noticed that there is a reasonable increase in the chance of spontaneous pregnancy. So I think when it comes to a lesser age, endometrioma with a good ovarian reserve, surgery will have its own advantages. A medical treatment followed by, generally what we do is we give surgery, we'll be giving some medical treatment like maybe Dinogest or GnRH agonist, and go take them through routine protocols of COS, IUI, and then going for IVF. And that probably may not work well. And medical treatment followed by surgery or IVF can be strategized if you also do an early surgery and later fertility treatment. Obviously, this depends on all the holistic approaches which I told you about. Obviously, test ovarian reserve prior to surgery. If low and the age is beyond 38 years, long infertility, think ART directly. If there is a tubal and male factor associated, obviously we'll think of ART directly. If there's a past surgery, typically we'll give an expectant treatment, but then do later IVF directly. If your client is not willing for IVF just after surgery, then you may have to land up giving some amount of expectant treatment, but do think of IVF directly. There's no point wasting time over controlled ovarian stimulation and IUI cycles in these women after endometrioma surgery. These are some diagrams which are explaining you the pathophysiological mechanism. You can just take a snapshot of it and that will help you. And I'm posting you one more picture of this paper which gives a neat flow of events which can be practiced in the patients of endometriosis. So I think what this paper really told us about two good take-home points. One is the endometrium is bad, and that is quite bad, and you need to give a large amount of GnRH agonist to make probably it better, and you'll have to give higher amount of progesterone because you just assume there's progesterone resistance. So I wouldn't mind giving an intramuscular progesterone and a 40 milligram to faston when I do FET cycles for patients of endometriosis. The second point is that in the therapy after surgery, don't waste your time in doing IUIs, and better to shift these clients back to IVF. So I think it comes to, before you plan, you need to have 1 or 2 sittings with the patients and the couple and the family, chatting it out how you're thinking about the whole process of this lady achieving a fertility, and also about what are the pros and cons on either side of the story, and that is going to involve good amount of counseling sessions, and a very individualized therapy will be very, very effective. I hope this helps you up, and I will most welcome your queries and comments. Though it's an old paper, it has a few take homes for all of us. Thank you.